Good morning, I'm Dr. Martin. Now, I fully appreciate that I'm not everyone's cup of tea. I'm more like coffee. And some people like me and some people don't. And some people like what I have to say and some people definitely do not. And this is going to be one of those lectures. And that's okay, because in all fairness, I just don't care. I'm very blunt. I'm from Missouri, and I just tell it the way it is. In medicine, there are only two types of doctors. Really, that's just it. There are two types of doctors. The first type is, for all intents and purposes, scared of their own shadow. And if they're going to do something in their practice, essentially everything has to be brought to bear to try to protect them so that they don't get in trouble. Meaning that if they want to implement anything in their practice, well, they've got to have the randomized controlled trials. They have to go to a course or a conference or 10. They have to have somebody that they can shadow and they can stand over their shoulder. And then they have to do it for months and months and months somewhere else on someone else's malpractice before they do it in their own office for their own patients. Now, on the complete opposite end of the spectrum, you have the providers that are much more cavalier. And because they lean into medicine, if it's within the scope of their practice, it's within the scope of their capability, and they feel like their patients are going to benefit. And after perusing literature, not aggressively studying for months and months, and after kind of maybe seeing a YouTube video, if they feel that's what the patient needs, they're going to do it. And the reason they're going to do it is very simple. Because if they don't, somebody else will. Well, today, I'm going to give every provider the ability to do both, right? To be hyper cautious, hyper conscientious, hyper aware of everything, and also tickle the fancy of those mavericks out there who are moving medicine forward, and they're not asking for permission, nor are they requesting forgiveness, because they understand that medicine is still an art form, and it is still the practice of medicine that moves medicine forward. And it has nothing to do with the randomized controlled trial. Now, the title of this lecture, Show Me the Money. I don't care which doctor you are, crazy cautious or, maven maverick. Whichever provider you are, by and large, if you're on the phone with me, this is the question you either really want to ask or you just come out and ask me. And you ask me this a number of different ways. It's typically, well, how do I market for this? How do I get more patients in the door so you can show me the money? How do I add this to what I'm currently doing? Show me the money. I'm drowning in overhead. I lost one of my biggest contracts. My insurance isn't paying me anywhere near what I was doing. And to be perfectly honest, I don't know how much longer I can actually continue to practice medicine, because the drug rep that I used to make fun of is now driving a nicer car than I am, and their company pays for it. The device rep isn't making a little more money than I am. He's making more than my whole practice, and we have 3 practitioners and 1 nurse practitioner, and he's driving a nicer car than all of us and living in a way nicer house. Show me the money. So I'm going to walk you through how we've decided to do that through my consultancy at Kingston & Cufflink's research. Now, it's taken a while to do this, and it's still not quite ready for public consumption. And so we're going to put some preliminary information up. But then we're going to drop something that's going to be very usable, very practical, and all of you can use in your practices. This is all couched under the biologic application of regenerative medicine products in your practices. Now, we've gone through at length and in excruciating detail how umbilical cord-derived biologics are regulated in the exact same way as PRP, stromal fat, and bone marrow aspirate concentrate. And just for a brief refresh, right? All of those products, umbilical cord-derived biologics, PRP, stromal fat, bone marrow aspirate concentrate, are all regulated by the FDA under Section 361. Now let's be very, very clear. PRP, bone marrow aspirate concentrate, and stromal fat are not FDA approved to treat anything. There is no FDA approved indication for any of them to treat any disease process. So when you're on the phone with me and you're saying, hey, Dr. Martin, where are the FDA guidelines? Where are the randomized, double-blind, placebo-controlled trials like those for PRP and BMAC using allogenic allograft products? And I just smile internally because I know what you don't, which is that you don't know what you're talking about. And that's okay. That's why I exist. That's why I do these videos. It's okay that you have no clue what you're talking about, all right? Because you probably weren't ever told or didn't read or just weren't given the guidance. PRP, stromal fat, and bone marrow aspirate concentrate are 510K cleared plastic kits. They're no different than a pen. Skin pens are actually a medical device. There's a patent on a specific skin pen that's sterile, that's used in surgery. It's not a human cell and tissue product any more than a PRP kit or a BMAC kit or a stromal fat kit. It's a 510K cleared medical device, like the TUI needle you put in the epidural space, the aesthetics cannula that you're driving under the skin to push hyaluronic acid or other fillers. But when you combine a PRP kit, a BMAC kit, an SVF kit with blood, bone, fat, it now becomes something different. It now becomes a human cell and tissue product. And now that plastic kit with blood in it, with bone in it, with fat in it, that you've processed in a more than minimally manipulated fashion falls completely out of regulatory guidelines. It is not homologous use unless it's applied under a same-day surgical exemption. The same-day surgical exemption is required to actually use the product. Now, this is going to blow your mind a little bit. The foundational randomized controlled trials, all of you who are crazy conservative are begging for, right, aren't homologous use. Every single one of those are not, well, most all of them are not homologous use. You want to know why? Because most of those trials are in vivo, in vitro trials, meaning they're taking PRP, spiking it with fetal bovine serum, plating it in cultured media, growing it, expanding it for the better part of 30, 60 days, and then taking that product and putting it back into a shoulder or knee. That's not homologous use. That's experimental use. And because it's being done under a randomized controlled trial, it's actually drug use. It's section 351 because the indication is to treat. Your randomized controlled trials that you're trying to beat me over the head with as the crazy conservative doctor are all drug trials that you can't do in your office. Notwithstanding the fact you don't have fetal bovine serum, you don't have the time to plate it and grow it, you don't have the ISO 7 certified clean hoods to do that. You don't have any of that stuff in your office, all right? But you're clinging to these trials. And you're saying, hey, look, I'm protected from the feds. I'm totally cool treating osteoarthritis with PRP. No, you're not. No, you're not. You're not at all. What do I mean by that? According to the FDA, to use a human cell and tissue product under strict regulatory guidance, you cannot use it to diagnose, treat, cure, or prevent disease. That's first and foremost. Number two, the product has to be for homologous use. That means a structural tissue allograft has to replicate the same function in the body that it does when you put it back in. I just talked to a neurosurgery group today. They spin down PRP and post-discectomy inject PRP in the intervertebral disc to try to encourage collagenous differentiation post-procedure. Is that homologous use? Not a shot, not a chance. It's done under same-day surgical exemption because it's not homologous use. Because there's no function for platelets or type 1 collagen in the nucleus pulposus because the nucleus pulposus is type 2 collagen, 90% type 2 collagen. So is there a homologous use to take a type 1 collagen, remove it from blood, spin it down, concentrate it, and inject it into an area where there's no type 1 collagen at all? Strictly speaking, that's not homologous use. That's experimental use. Let's talk about putting PRP in a knee joint for a patient with osteoarthritis, because that's the ICD-10 code you're using, osteoarthritis. And you're using a human cell and tissue product that you're spinning down and you're putting in the knee. Now, from a strict homologous use standpoint, is there any blood floating around in your knee joint right now? No. Unless you just got in an auto accident and maybe a dashboard injury and you've got a hemarthrosis of the knee. So is it really homologous use to put a type 1 collagen that's going to cause a ton of inflammation because it works by way of a pro-inflammatory response in the knee joint to stimulate type 1 collagen? No, right? And if you're doing it to treat osteoarthritis, you're using that PRP as a drug. So the randomized controlled trial that you are going to use in defense of your process actually renders your whole procedure out of regulatory compliance, because a randomized controlled trial to treat osteoarthritis is a drug trial, section 351. But you applied it under section 361 and miscoded it. You used the wrong ICD-10 code. You used a disease code when what you should have used is a cartilage-based defect code like internal derangement. But again, you're listening to your reps. You're listening to whoever's selling you those 510K cleared kits, who are promising you that it's totally approved by the FDA to treat osteoarthritis. Where am I going with this? The state of Florida just passed a very large stem cell bill, a very large stem cell bill. In that stem cell bill, a lot of people are really excited, really excited. The problem is that bill is its own kind of quicksand. No different than you beating me up with randomized controlled trials when you don't realize those are actually drug trials, Section 351 trials, and you're using those to justify a 361 application. State of Florida said that you can use any stem cell product to treat osteoarthritis, meaning orthopedic conditions, pain conditions, and of course, cosmetic use. So I'm in the state of Florida. I'm super happy. I'm all pumped. I've got my Wharton's jelly, or I've got my stem cells. I'm advertising stem cells. I've got billboards going up. I've spent $500,000 for these great infomercials to market stem cells, to treat osteoarthritis, because state of Florida says I can use it for pain, for orthopedic surgeries, or orthopedic indications, for cosmetic. So now I can use the term treat, right? 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 So you mean the federal government, the FDA, is just going to be like, well, I no longer see the state of Florida. I don't see Florida on the map anymore. It just doesn't exist. Now our country has 49 states because Florida doesn't exist. Utah has a stem cell bill. Utah doesn't exist. Florida's now a free-for-all. Do whatever you want. Market whatever you want. Say whatever you want. It's free love. It's stem cells for everybody. Is it? It's interesting that the most conservative physicians who want to beat me up over randomized controlled trials are the fastest to run out and want to start marketing for stem cells. It's quicksand. The reason it's quicksand is because even though you might be in compliance using products under homologous use paradigms for orthopedic conditions, pain conditions, cosmetic conditions in the state of Florida, you are out of compliance with the federal government. Can you still get a warning letter from the FDA? Oh, yeah. Can the FDA still come in and shut down your practice? Yeah, buddy. Can the FDA decide they're going to do a site visit and they're going to spend 8 hours a day, 5 days a week for 6 weeks at your office to review every single patient interaction to make sure you're compliant with federal statutes in your office, whether you're in Florida or not? Oh, yeah, they can. And they have. I know 3 doctors it's happened to. Now, do you think when the federal agents, 3, 4 of them, right, who all come brandishing a weapon, spend that amount of time in your office, they're just not going to find anything? Just be like, hey, Dr. Martin, we spent 6 weeks in your office, 8 hours a day. We stood over every single patient interaction. You're perfect, man. This is like an episode of Dude Perfect, right? We just half court swoosh, back turned. Now, you're probably going to jail. You're probably going to jail. They're probably going to find so much in your office, you're going to lose your license and probably go to jail. So whether you are the crazy conservative doctor or you are the maven maverick doctor, is there a way around both? Yeah. It's observational research on an experimental use paradigm. Now, I will say I have been remiss. I've been talking about this for a little over a year. It's taken me a little bit of time to perfect the process. What do I mean by that? I've written in whole or part 11 different papers that have now come to publication. All of that was observational research. So I know it well. Under an observational auspice, no matter what you are doing, it's experimental use. So, if you wanted to do observational research and you wanted to take type 2 diabetics and you wanted to do quarterly applications of nebulized exosomes and track their HbA1c and track progress over time, could you do that? Yes. Under experimental use, doing observational research. Okay? Could you treat diabetes doing that and write a randomized controlled trial? You might get away with that. You might be able to publish that study, right? You would also run afoul of federal statutes, and maybe 2 weeks after that was published and got a bunch of fanfare, you'd probably get a warning letter from the FDA that you're using human cell and tissue products as drugs to treat a disease process. What would happen with your license? I don't know. What would happen with your practice? I don't know. There are 3 levels of engagement from the feds. The first, a warning letter. We noticed that you're making claims using human cell and tissue products. We're making you aware that we're aware. That's, the yellow light. The orange, right? You see it turn yellow when you're going to hit the accelerator and go through the light. I confess I do that all the time. So it's not really yellow, it's not really red, it's a little bit orange. Orange is terrible. The orange is a cease and desist. The FDA sends you a certified letter and says, you are using human cell and tissue products in your office as drugs. You are using unapproved drugs to treat patients based on claims you have made in the office, on the internet, other places. Cease the practice of medicine. Not stop using biologics, cease the practice of medicine. Now you would think that that is the red light. It's not. It's not. Because even if you have to cease the practice of medicine, you can still go do other things. Because the red light is the certified letter letting you know when they're showing up on your doorstep. And they're going to be at your office 3, 4 federal agents deep for 8 hours a day, every day, all week for 4 to 6 weeks. And rest assured, when they're done with the most abusive and crazy forensic cavity search you've ever experienced, and it would make a forensic audit from the IRS look pleasant, you're most likely going to lose your license and or go to jail. So, why not do experimental use for everything? Let me walk this through for you. What I have painstakingly done over the past 6 months is take, in my own office, an SF-36, right? So we used SF-36. We used an oswestry disability. We used an NPRS. We used WOMAC. And we used quality of life scales. And we took all of those and we boiled the most clinically relevant questions out of all of those scales into 15 questions. And those 15 questions will be available to every single one of you in a jot form. It will be from Kingston and Cufflinks, and that jot form will specifically be for experimental use. Now, the reason I have all of this up here is to show you the comparison if we're using a biologic. If we're doing a randomized controlled trial, right, where first line is weight loss exercise, therapy, and maybe braces. And treatment is steroids, hyaluronic acid, or PRP, right? I don't consider this treatment, but randomized controlled trials have used this as treatment. I think that's intentional misinformation because PRP is a human cell and tissue product and it can't be used to treat anything. Don't care what the study says. That's a drug study because it's used to treat. All right? When we do randomized controlled trials, we are looking at after the fact therapy. We're using steroids because somebody's got degenerative arthritis or a traumatic injury. We're just going to quell inflammation, and because we know steroids are catabolic, it's going to break that joint down. The literature on HA is so poor, I don't know why anyone uses it, right? One of the more recent randomized controlled trials and systemic reviews demonstrated that HA was no better than normal saline. And as a matter of fact, normal saline had a much better side effect profile. In fact, the adverse events with HA were so significant in a recent systemic review that the authors recommended against the use of HA for patients with osteoarthritis of the knee. PRP, if you've got fetal bovine serum, if you've got the time to plate and expand that product, sure, use PRP. Otherwise, it's a cell-poor product. You're putting in a cell-poor environment. You're going to get a piss-poor result. What are we doing when we're doing observational research? Well, our goal is not to treat. Our goal is to prevent. What are we trying to prevent? Well, in this day and age where everyone is basically just trying to keep people from, dying, right? We're just propagating disease. We're not actually trying to get anybody better. We're just propagating disease. If you're going to use a biologic for experimental use, you might find some pretty interesting things. You might find that your patients don't dose escalate. They may be on prednisone because they have rheumatoid arthritis. But under experimental use, maybe you're using nebulized exosomes on a quarterly basis to systemically downregulate their inflammation. And if you are using this jot form at 0, 3, 6, and 12 months, and you're actually collecting data, you can actually say that you're using those exosomes for experimental use, not to treat their rheumatoid, but to improve their quality of life under experimental use. Maybe your goal is to take pain patients and prevent them from using narcotics. And you've got a patient who's got a degenerative joint, who's on NSAIDs, who's on tricyclics, right? Who's on muscle relaxants, and the next step is narcotics, and you don't want to prescribe that. You don't want to deal with that. Maybe your experimental use is, Wharton's jelly applied to that cartilage-based defect in the knee. And by tracking outcomes 0, 3, 6, 12 months, you can look internally not only at their quality of life, their function, and their pain, but add the presence or absence of narcotics by prescription. That is experimental use, and that is significant. Because if you can prevent a person from starting narcotics, you can prevent a predictable narcotic dependence. Anyone who's in pain medicine like me knows that if I put you on narcotics, and I don't care who you are, there is a pharmacologically predictable narcotic dependence within 90 days. 90 days. Steroid use. We all know that steroids are catabolic. We know that they break structures down. Okay, take that same joint, right? Go ahead and apply a biologic to that knee or that hip or that shoulder for experimental use. Get your jot form filled out. 0, 3, 6, 12 months. And track the number of cortisone injections your patients are getting, not just from you, but from every provider. If you follow the trend, you're using this jot form as a baseline. You're adding another element to it based on the specificity of your practice and, moreover, based on personal interest within your practice. Those that are crazy conservative, they don't want to write narcotics. They don't want to see patients on 60 milligrams of prednisone. They don't want to see all the side effects. Great. Be your own solution. This is how I'm empowering you, because it doesn't matter whether you're the crazy conservative or the maven maverick. I'm going to give you the ability to be your own experimental use, to create your own observational studies, so that you are the research. Maybe you want to prevent people from having surgery. Awesome. Get your jot form for every single patient that you're doing hip injections on. Track the number of surgeries your patients who have gotten, say, Wharton's jelly in the hip 2, 3 times, and fill this jot form out. 0, 3, 6, 12 months. And then maybe twice a year thereafter, and track how many of those people ended up going to hip surgery. You know what? That's fabulous research, whether you publish it or not. Because after a year or two, when a patient comes to see you and they have a bad hip, and they've been to see 2 surgeons and both have said hip replacement, you can say, well, as a matter of fact, I have 7 patients that I've been tracking now for a little over a year. And all 7 of them had bone-on-bone arthritis of their hip, right or left, sometimes both. And we applied a biologic under experimental use. And I tracked their outcomes on an observational basis. I did an observational study using this jot form. And what I can show you very clearly is that on a statistical basis, their quality of life, their pain, their function improved. But more importantly and more specific to you, 1 out of those 7 patients ended up having surgery. And that's because they fell and broke their hip, not even because they wanted to have the surgery. What I'm offering you isn't a way to argue me or argue the next rep that calls you on the phone. What I'm offering you is how to show you the money. This experimental use paradigm is a fabulous, fabulous marketing tool. Say you want to charge $3,000 for a joint injection. Okay. If you fill out this jot form at 0, 3, 6, 12 months, I'll give you $500 off every single one of your injections. That's pretty great marketing. Say you are passionate about diabetes and you're an endocrinologist. You want to do nebulized exosomes. And there are really no good clinical trials for diabetes other than GLP-1s and whatever else, right? But that's not what you're passionate about. You want to prevent dose escalation, steroid use, potential surgery from joints that fall apart from all that systemic hyperglycosylation. And maybe you want to give, exosomes, and maybe you want to nebulize in one observational group every 6 weeks, and in another observational group you want to administer quarterly. And then the rest of your practice is control. And all those patients get a discount for participating in observational research under an experimental use paradigm. And you look at function and quality of life and pain, but you're also tracking how much insulin they're taking, the dose of their oral hypoglycemics, and their HbA1c. Is that a fabulous paper to publish? You bet. You know what else it is? The best marketing in the world for the next diabetic that walks into your office that's considering, I don't know, an insulin pump, and they're a type 2 diabetic. And you get to say, well, you can use an insulin pump and they work, right? They have risks, hypoglycemia, these type things. But actually, I'm doing an observational study in my practice using inhaled biologics. This is completely experimental. These products are umbilical cord derived products. They're not approved by the FDA. They're cleared by the FDA for experimental use. And that's what I do in my office. But to go a step further, I do give patients a discount to participate in this observational research. And even though the biologic's expensive, it's valuable to me, incredibly valuable, to get the data, to create the research. And so I'm going to give you a $500 discount off that nebulized therapy that's $1,000. I'm only going to charge you $500. And we're going to do this on this regimen. And every time we administer, I'm going to give you a huge discount. And all I ask is you fill out 15 questions at 0, 3, 6, and 12 months. But I'm going to be checking your labs. I'm going to be checking your HbA1c. And what I can tell you from the 22 patients that have already enrolled in this observational research, these are the trends that I'm seeing in their dose of oral hypoglycemic. These are the trends that I'm seeing where we're not having to dose escalate. These are the trends that I'm seeing with regard to their HbA1c. Would you be interested in the alternative to an insulin pump and be enrolled in our observational study? Marketing for biologics is a tap dance, and you can be out of rhythm very, very fast, no matter what state you're practicing in, with the federal government and with federal oversight. You can't be out of step with regard to federal regulations if you're doing observational studies under experimental use. There is no better way to practice prevention-based medicine, to build data, to be part of the forward movement of medicine, and to objectively demonstrate within your own practice how you can help the next patient that walks through your door. I'm Dr. Martin. Please have a very blessed day.